So nowadays what we do at Tamira is, even if we do, let's say somebody has multiple pregnancies and during the pregnancy, sometimes for the baby's head to come out, they make an incision on the vagina called episiotomy. Now this episiotomy cuts the mucosa and muscle, and your gynecologist obstetrician sutures the muscle and the mucosa after the baby comes out. Yes. But sometimes the muscle approximation is not complete, and so the vagina becomes really lax. So in such patients, after careful examination, we do repair that lax muscle by doing a surgical procedure called vaginoplasty. But that's done on the posterior wall, and you must assume vagina to be a round structure. So just imagine you have a round structure. If the circle is complete, when you tighten, it will reduce the circumference. So it becomes tight. Whereas when the circle is incomplete, because after an episiotomy the muscle is dehiscent, when the muscle tightens, the circle becomes larger because the muscle is retracting. This is when you feel that post multiple pregnancy, as you age, you're not able to tighten your vagina, and that is, you don't feel that completely happy during sexual intercourse, and so many patients approach us for correction of these. And of course, in such patient, we do vaginoplasty initially, then put them through these non-surgical procedures to give a 360-degree treatment. But what is surprising is, earlier for vesicourinary incontinence, the main treatment used to be something called a sling surgery. Yes. And this is a major surgery. And today, a significant amount of vesicourinary incontinence we are able to correct with the non-surgical method. Yeah. So let's ask Smriti, can you tell what's your protocol for stress urinary incontinence, and how many times do they have to come, and what is the procedure?
Yeah. So the stress urinary incontinence, as Dr. Jayanti mentioned, so how does it work? How will an intravaginal thing help in improving the stress urinary incontinence? So when we talk about the vagina, the tube, the upper surface of the tubes is where it contacts with the lower end of the urethra and the bladder and the urethral orifices. So when we are doing the treatment from the vaginal wall, so that is, as I said, the penetration is more than 4 mm. So it treats the urethral and the bladder wall as well, and that's how it improves the contraction over there, the detrusor muscles and the sphincter as well. So what happens is, why do somebody gets SUI? They get because the laxity of the urethra, the orifices, they are not able to hold the urine. When we do the treatment over there, which is included by MNRF, that is the microneedling of the area. Why? To improve the collagen formation over there, to improve the mucosa, and also to improve the strength by the electrical muscle stimulation. So that becomes strengthened, and then the lady who was not able to hold the urine, she had to run to the restroom, or at some point she was wetting her underpants because she was not able to hold, or maybe a few drops of dribbling. She is now able to hold it completely if it is mild to moderate, or she is able to hold it till she goes to restroom and passes the urine without a fear of having dribbling on the way.
So basically what the MNRF does is, we are trying to approach what we call the periurethral tissue. So you have the bladder. Bladder is, what holds the urine. And from the bladder, you have what is called a urethra, and which comes out and opens into the external meatus. Yes. Now the passage around the urethra, that is the passage from the bladder to the external meatus, if this becomes loose, valve is not tight, when we cough, sneeze, the intra-abdominal pressure rises, that squeezes the bladder, and that pushes the urine, and you have dribbling because the valve is not tight. Now if you tighten or increase the collagen elastin tissue in the periurethral space, it's going to narrow down the urethra. So that's exactly how this works. So we are approaching the periurethral tissue through the vagina, which just sits just below the urethral passage. So by heating the upper vaginal wall, the radio frequency that is applied to the upper vaginal wall transmits to the periurethral tissue in the lower surface of the urethra, and that actually enhances improved elastin collagen in the periurethral tissue, which actually reduces the vesicourinary incontinence. So it's not just the machine, but the treating surgeon also have to understand all of this. You might have to be given different energies, different number of sessions, work on this until you develop that significant elastin collagen in the periurethral tissue to correct them.